Hello everyone. Today we are going to talk about a group of medications that are called antiepileptics or anti-epileptic drugs. This is an important class not because they are used to treat a condition called epilepsy, but these medications are also good in treating other diseases, as we will see later. So we are now going to study the anti-epileptic medications. To start with, we need to understand the differences between some definitions. So there is something called seizures and something called convulsions. Seizures are abnormal, excessive neuroactivity in the brain. So neurons in the central nervous system are overexcited and they are all active. This is seizure. And this is only can be seen or can be recorded by something called the EEG, where we put poles or electrodes into the skull and we detect the neural activity of the neurons in the brain. On the other hand, convulsions are skeletal muscles where they are a mix between contraction and relaxation. So convulsions is a symptom or a sign that we can see on patient, where we can see the patient in contracting and relaxation of skeletal muscles. So there are differences between seizures and convulsions. Now, every convulsion, there is contraction and relaxation of skeletal muscles, usually is or always accompanied with seizures, but not every seizure is accompanied with convulsion, as we will see later. Now, the convulsions may happen without any previous condition. So, for example, head injury, drug overdose, toxins, all of this may produce convulsions to the patient. Epilepsy now, on the other hand, are seizures, so the problem is in the central nervous system, and that seizure is accompanied with or without convulsions or skeletal muscle activation relaxation, without immediate underlying cause. We already know that convulsions may happen after the head injury or drug overdose or electrolyte imbalances or infections. But epilepsy, there is no predisposing factor for these convulsions that, of course, associated with seizures. This figure shows an EEG where we can see that before this point, these areas in the brain, some of them are more active than the others. You can see to this line here. So this area is more active than, for example, the area here. This area right here is more active than this. But at some point, all of them become more active. So this is an example of the seizure, and it's recorded by the EEG. So the definition of epilepsy is they are seizures that are located or due to abnormal function in the central nervous system, and it is a chronic disease. That means it's happening from time to time. It's not only one time, it's happening from time to time. So it's periodic and it's unpredictable, where the patient does not predict when he will get the seizure or the epilepsy, and it's uncontrollable. So the patient also cannot control when to start the epilepsy or not, as well as he cannot control himself while he is under the attack during convulsions. Now, what are the causes of acute seizures? And again, here we're talking about specifically seizures. So seizures can happen due to trauma, encephalitis, drug, birth trauma, hypoglycemia, electrolyte imbalances, extreme alkalosis, withdrawal from depressants, tumors, and hypoglycemia, and many other factors that may produce seizures and that also may produce convulsions. However, if there is no underlying factor among these, and we cannot determine the reason for this seizure or convulsion, and it's periodic, so it's coming from time to time, so then we call that there is an idiopathic for this seizure, and the patient can be diagnosed with epilepsy. Now, you probably know this classification of epilepsy more than this slide. This probably classification is a little bit old. There is a newer and more, I think, clarified classification of seizures. So there are partial seizures, partial or focal or generalized. Partial means part of the brain there is a hyperactivity. Generalized seizure, actually all the neurons in the brain are hyperactive or excited, and that usually accompanied by loss of consciousness. Partial seizure is usually not accompanied by loss of consciousness. There is probably there is multiple subtypes of partial seizure that could be simple or could be complex. Complex, there would be altered consciousness, but in generalized seizures will be complete loss of consciousness and no memory. Generalized seizures also has multiple subtypes, such as tonic-clonic or grand mal, absence seizure or petit mal, myoclonic, atonic, and many other subtypes. The most famous one is the tonic-clonic seizure, where the patient can start activation or contraction and relaxation of his skeletal muscles. That's tonic-clonic seizure, and all his body. In the absence seizures, on the other hand, there is no contraction or relaxation of skeletal muscles. There is a seizure in the patient, so there is abnormal excitation of the central nervous system neurons that can be detected by the EEG, and there are multiple videos on YouTube you can look for. But at the same time, there is no convergence in the skeletal muscles, so that is an absence seizure, but the patient lost his consciousness. A third special type of epilepsy called status epilepticus. In the past, the definition of status epilepticus is a continuous contraction and relaxation of skeletal muscles or convulsions for 30 minutes or more, but recently it was modified to be 5 minutes or more of continuous convulsions, so that is status epilepticus. It has special treatment precautions. So this is an example of tonic-clonic seizure. So tonic, where there is the patient starts with either a contraction or contraction of flexor muscles or extensor muscles in the body. It depends on the patient, and that lasts for 10 to 20 seconds. So that's a continuous contraction of the skeletal muscle. And then after that, there is a clonic phase. Now there is a multiple contraction and relaxation of the skeletal muscles. This is the most dangerous part of the tonic-clonic seizure, because in this case the patient cannot breathe, because the diaphragm is also a skeletal muscle, so if it's contracted, it cannot be relaxed, so the patient cannot inhale or exhale. Now this lasts again for a few seconds, up to 20-30 seconds, and then there should be go to this phase. It is also important, before we go into pharmacology, what is the best approach for treating patients while he is under the contraction or relaxation. So there are some things that the doctor, or not necessarily the doctor, but at least the person who is around the patient when he got the convulsion, there are things that he can do and things he definitely cannot do. Things that the patient can do, or the accompanied person can do, is remove harmful objects nearby, because the patient cannot control his skeletal muscles. So he may hurt his skull, he may hurt his bones in general, or his skin. So any sharp objects or harmful object nearby you can remove. Also, if you have a pillow or a cushion, you can provide them around the patient, so he will not hit the ground, he can hit the pillow or the cushion. And after he finished contraction and relaxation, you can help the patient to breathe by putting the patient into the recovery position, which is right this, where he put in his sides, because usually after the convulsion, there is a huge, strong salivation or hypersalivation from his mouth, and make sure that the throat is open for better respiration. Things that the accompanied to the patient cannot do is restrain the person movement. If the person starts moving, besides hurting himself, because he cannot control himself, he can hurt you and kick you without controlling that action. You don't need to put anything, especially your fingers, in his mouth. Don't put anything in his mouth because he cannot control himself and he may bite you very hard. Sometimes in some conditions in the hospital, if the patient starts to have the convulsion inside the hospital, the nurses and the doctors are trained how to protect the patient and to put things in his mouth. But outside the hospital setting, and people are not trained, we don't put anything in the person's mouth. We don't give the patient anything to eat or drink until they are fully recovered and they can control the swallowing reflex. So, the aim of the treatment in patients who are diagnosed with epilepsy is to know the underlying cause and treat the underlying cause, and then the patient will get cured. However, until now, because we don't know the underlying cause, so there is no cure for this treatment. Thus, the aim of the treatment is to decrease these convulsions, either by complete suppression of these seizures, so they will not happen, even if we do not treat the underlying cause, if we find it, or we decrease the number of episodes with minimal side effects. So if the patient suffers from 10 episodes per year, so then if we decrease that up to 1 episode per year, that is a great achievement and improvement in the patient's condition. And we have to balance that with the side effects of the medication that we give to the patient. How can we do that? Of course, by either pharmacological or non-pharmacological approaches. One type of non-pharmacological approaches is called vagal nerve stimulation. So in vagus nerve stimulation, the patient is connected with a machine that generates electrical impulses through this wire, and this wire at the other end is attached to the vagus nerve, which is the 10th vagal nerve, the 10th cranial nerve, and keep sending stimuli to vagus nerve, and they found that this procedure can decrease the number of episodes or the risk of epilepsy in such patients. This treatment can be used in other conditions. One of them is epilepsy. Now, the mechanism of action why is doing that is not well known, but usually it's an add-on therapy, so it's in adjunct with other treatments, as well as with conditions that are not responsive to other treatments. Now let's talk about medications that we talk about. There is a list for medications that we will study today, and I group them into different categories. Like this is a group, and this is another group, and this is another group, and that depends on their mechanism of action. And we think about the mechanism of action of medications. So the condition, the epilepsy, the epileptic patient has a lot of excitation or activation of neurons in the brain. So definitely, by any mean, any drug of these will decrease this activation. So you can think about the mechanism of action by decreasing the excitation or the risk of excitation of these neurons. Thus, if we think about the sodium channels, voltage-gated sodium channels, we have a group of drugs that can decrease that voltage-gated sodium channels and inhibit the excitation of neurons. We can think about the GABA receptors, and some medications can increase the GABA transmission, and that GABA, since it's inhibitory, it will produce inhibition to the neuron. As well as we have the calcium channels inhibitors, because calcium itself, if it's inside the cell, it will produce depolarization. So these medications can decrease calcium channels inside the neurons and thus decrease their firing. Before we go into each drug, let's talk about principles of using the anti-epileptic drugs. So usually we have a lot of people who may suffer from convulsions, and we don't start treatment or we don't diagnose the patient with epilepsy from the first episode. We wait until the second episode, and recent change in the protocol, they maybe wait until the third episode of convulsions before we start any medical conditions. And you can guess why, because of course they will suffer from side effects. Monotherapy is always better than combination. But if one monotherapy is not working, so we may start changing to another monotherapy. If the other monotherapy is also not working, so we may think about combination of both drugs together. When we increase the dose of the antiepileptic, we want to find a dose that is efficacious, so it decreases the number of episodes, but at the same time, it can be tolerable by the patient, so he will not suffer from side effects. So we increase the dose slowly. These drugs has many side effects, and one major problem with these medications, if we decided to stop treatment, we don't stop the treatment abruptly. So if a first medication is not working and we want to shift to or like is not very efficacious and we want to change into or there is a lot of side effects from the first medication and we want to change to another medication because it has probably less side effects to the patient, we start to decrease the dose of the first one as we increase the dose of the second one. We want all the time the patient to be covered, because once you stop the medication, that will produce rebound, convulsions, and epilepsy. So, and the other thing, if we decided that the patient may be now between two parentheses cured, or he did not have epilepsy or seizures for 3 years, consecutive 3 years, then we can think to take the drug of the patient. And when we take that, we should do that slowly and in increments. We decrease the doses, not abruptly, and because that will increase the risk for rebound seizures. As I mentioned earlier, a good thing about these medications that they can be used in many other conditions, as we will see later. So let's talk about each drug individually, and let's start with the first drug, which is Phenytoin. Phenytoin, which is the direct name for it is Dilantin, is a medication. It's the prototype, and it's mainly used for grand mal or tonic-clonic seizure and complex partial seizure. It is not good for absence seizure, and one other indication of using Phenytoin is for patients who may suffer from digoxin toxicity. They found that Phenytoin may work as antiarrhythmic drug, and it is one of the drug of choices giving Phenytoin in patients with digoxin toxicity. Now, the drug is the Phenytoin enhances the inactive form of sodium channels. What is the inactive form? So the sodium channels, voltage-gated sodium channels, they have two gates. So from the upside here we have this, the extracellular fluid, and the inside we have the cytoplasm. And so they have two gates. Usually the outer gate is closed and the inner gate is open, and that is the closed form of the channel where sodium cannot go in because the outer gate is closed. If the neuron is excited during, for example, epilepsy, so both channels are open, and now sodium can get into the cell, producing depolarization and hyperexcitation of the neuron. Now, after some time, and this is the open form of the channel, after some time, now the channel has an inherent mechanism by decreasing the flow of the sodium inside the cytoplasm by closing the inside channel, or the inside channel, not the outer, the inward channel, and that also will decrease sodium going there. So for this channel to block to be closed, it has to be first be activated, and then it will be closed. Phenytoin will come to this form of the channel, which is called the inactive form, where the inside gate is closed. It will come to this form and fix the channel into that place, and that's why it's closed. Now, a good thing about Phenytoin in this mechanism, it means that it's selective for the neurons that are active. As I mentioned, this is the closed channel. If they get activated by epilepsy, for example, then the channels will become in the inactive form. And this is where Phenytoin is working. So they can describe Phenytoin as voltage dependent, use dependent, and time dependent. It will go exactly to the channels that are already excited, and they maintain them into the inactive form. Phenytoin has a lot of side effects. Again, it's the prototype, and we have many other drugs that was discovered later, and they are now preferred over phenytoin because of the reason of the side effects. Examples of these side effects, of course, the first one is CNS related, such as nystagmus, ataxia, tremor, double vision, and others. We will see this side effect in all other antiepileptics because they all work in the central nervous system, and we always have the risk for CNS related side effects. Phenytoin will decrease the folates in the blood, and that may produce megaloblastic anemia. It is well-known drug to be teratogenic, so it's contraindicated during pregnancy. We have other drugs that are also contraindicated in the anti-epileptic medications, and some of them are safe. We will study them later. And the phenytoin increases the risk for Stevens-Johnson syndrome, which is a reaction to the skin, and it may produce lupus as one example of medications that drug-induced lupus. A very well-known side effect of phenytoin is gingival hyperplasia. This is probably important for dental students if a patient comes to the clinic with this enlargement. So this is not inflammation by itself, so the reason is phenytoin, and sometimes this needs to be excision for it, or sometimes to stop the medication if it's producing problem to the teeth. And finally, it increases the liver enzymes. It's an induction of liver enzymes and will produce many drug-drug interaction. So they will interact with the birth control and vitamin D, because they will be metabolized through the same enzymes that are stimulated by phenytoin. So that will produce the birth failure of controlling the birth, or the pregnant control the mother will lose her control over the pregnancy, as well as it will decrease vitamin D. We have one prodrug that's called phosphenytoin. That is, it's a prodrug and it's given parenterally. Let's move to the next drug, which is carbamazepine. Now let's talk about carbamazepine, or its trade name is Tegretol. It's very well-known medication, and similar to phenytoin, it is effective against grand mal and complex partial seizures. For patients who suffer from absence seizure, it is contraindicated, as some reports indicate it may worsen the condition of absence seizure. The good thing about carbamazepine, it is the drug of choice in one condition that attacks the trigeminal nerve, which is called trigeminal neuralgia. In this condition, the patient will suffer from severe pain after simple or light touch at areas of the skin that is innervated by the fifth cranial nerve, which is the trigeminal. And the drug of choice again is Tegretol. Also, it can be used in bipolar disorders. It has a long half-life, and similar to phenytoin, it has a lot of side effects, including aplastic anemia. It is teratogenic, and it's category X in pregnant women and for pregnancy. So it's if a patient who is planning to get pregnant, this is not a good drug to maintain the patient on. Of course, there is some central nervous system related side effects, and similar to phenytoin, it will enhance the liver enzyme, so it will produce drug-drug interaction with warfarin, theophylline, and oral contraceptives. There is another drug that is structurally related to carbamazepine that's called oxcarbazepine. It's a prodrug that is metabolized into the active form. The active form is not carbamazepine, but structurally oxcarbazepine is related to Tegretol. They found it as safer in pregnant women, as well as it has less side effects, especially the side effects related to liver enzymes. So it does not induce liver enzymes, and it does not produce or have a lower risk of aplastic anemia. Let's move to the next one, which is ethosuximide. And by now, you should know that the phenytoin and carbamazepine that we talked previously, they are not good in absence seizure. That's where ethosuximide got its main advantage, where it is the drug of choice in patients who suffer from absence seizure. And once again, absence seizure is the seizure where the patient, which are usually kids, they lose their consciousness but without any convulsions. So there is no activation or relaxation of skeletal muscles, and that may happen up to 100 times per day for the patient, and that is very dangerous for the kids, for their study and other things. It has a long half-life, and of course they have side effects that are related to the central nervous system as well as to the gastrointestinal tract. Let's move to the next drug, which is valproic acid, very old valproate, very commonly used in the clinic. This drug is good in multiple types of seizures, such as absence seizure, tonic-clonic seizure, as well as status epilepticus. We will come back to status epilepticus toward the end of the lecture. Valproic acid, similar to other drugs, they can be used in conditions other than the epilepsy, such as bipolar mania and mood stabilizer. It has some side effects that include the CNS and GI related side effects. This drug was black boxed for its liver toxicity. It's produced inflammation of the liver. In the liver enzymes, it inhibit liver enzymes, so it's produced liver failure, decrease in liver enzyme activity. So we can think about drug-drug interaction. Similar to other drugs we talked about, it is teratogenic, so we have to be very careful in pregnant or patients who are going to get pregnant. And it is a protein-bound drug, so it may compete with other medications on albumin in the blood. Let's move to the next group, which are benzodiazepines and phenobarbital. Although they are discussed, they will be discussed briefly here. We will have a different topic that covers these medications in details, which are sedative hypnotics. So they sedate the patient, and thus they get this advantage to give into patients who have epilepsy, because they may sedate the patient and during the acute conditions. So benzodiazepines and phenobarbital, they work through the potentiation of GABA function. Examples for benzodiazepines are diazepam and lorazepam, that are most commonly used in epileptic patients. These are the drug of choice in the cases of status epilepticus. Phenobarbital, in comparison to benzodiazepine, have a low therapeutic index. So the major ones to be used in the clinic is benzodiazepines. Phenobarbital is mainly used in case that benzodiazepines and other medications did not work in patients with status epilepticus. These drugs, the main side effect is sedation, and we will talk about those benzodiazepine and phenobarbital medications in the sedative hypnotic lecture. The next drug is lamotrigine. Lamotrigine has multiple mechanisms of actions. It can be used in partial, generalized, absence seizure if other medications did not work. This drug is metabolized through the liver, so if we combine them with other medications such as phenytoin or valproate, we have to adjust dose from time to time, because phenytoin and valproate will increase and decrease liver enzyme activity respectively. Of course, they have other indications, just similar to previous drugs such as bipolar and neuropathic pain. Side effects, central nervous system related. In pregnancy, they are category C, and usually these are one of the medications that the first choice for a clinician in case they want to prescribe anti-epileptic for a pregnant woman. One important side effect for this drug is a severe skin reaction. This drug is highly associated to increase the risk of severe skin reactions such as Stevens-Johnson disorder. This is an important information. Next, we will talk about the two drugs, gabapentin and pregabalin. Probably most of you heard about them. Pregabalin, the trade name for it is Lyrica, and gabapentin is Neurontin. These medications are structurally related to GABA, but their mechanism of action is not exactly known to be inhibiting or activating GABA receptors. These drugs in epilepsy are used as an adjunct therapy with partial seizure, but their biggest clinical indication is for their neuropathic pain activity. So they decrease the post-herpetic neuralgia, which is the pain happening at the site at the site of infection after shingles by the varicella zoster, or in general neuropathic pain. Patients who suffer from neuropathic pain by, for example, discs or the any other type of neuropathic pain. So these are usually the drugs of choice. If you remember previously, we talked about opioids as one choice of using in patients with neuropathic pain. But yet, these are not the first choice opioids. There are other medications. These medications are the first choice usually right now for clinicians in case of neuropathic pain. And they are very good drugs. They are well tolerated by elderly, and they have fewer side effects. These side effects may include sedation and euphoria. And euphoria means that they feel happy, the patients, and that's why some clinicians think that these medications could be abused by patients, and now their prescription is limited in the clinic. Let's talk about Philbamate. Philbamate is a drug has multiple mechanisms of action. Major side effects is fatal aplastic anemia, hepatic failure, and it's used in refractory epilepsy. Another drug which I did not put in the list before, which is Levetiracetam, or the trade name is Keppra. Keppra has unknown mechanism of action, and but there is a proposed mechanism of action you can read in the book or literature. It's used in partial seizure or as adjunct in generalized epilepsy. Side effects include, of course, dizziness and somnolence, where the patient may suffer sleepy, so maybe produce some sedation. Please look at its side effect in the literature or the proposed side effect in the literature. So this is a summary of the medications we talked about. This is taken from the medical letters that was summarizing the latest guidelines for using medications in general. This is about antiepileptics in 2013. You can see that in generalized seizures, the drug of choice, lamotrigine, carbamazepine, levetiracetam, and there's some other alternatives, second choice. This is for the partial or secondary generalized seizures. If you look, for example, at absence seizure, you see ethosuximide is the first choice, and then valproate. But we have also other conditions or other drugs that if the first two did not work. For a primary generalized tonic-clonic seizure, valproic acid, lamotrigine, levetiracetam. You can see that Phenytoin now it's the second choice because of its side effects, and same with other types of epilepsy. Now let's come to the special type of epilepsy, which is the status epilepticus, if the epilepsy lasts for more than 5 minutes. Usually we start with the benzodiazepine, the drug of choice, with either diazepam or lorazepam, and of course that should be done in the clinic to be given IV. And as I said earlier, the nurses and the doctors are trained on giving these medications in patients while they are under convulsion. That's usually accompanied by giving either phenytoin or valproic acid or phosphonitoin to the patients, and we wait for the patient to recover. If they did not work, so then we think about the barbiturates, the alternative for benzodiazepine. And if they do not work, all of these medications, so then we can think about putting the patient under general anesthesia, and then we intubate the patient. We insert a tube into the throat or to the trachea, where we provide general anesthetist, and we provide an artificial respiration until we find why the patient is not responding to the medications. In the epilepsy, we notice that some drugs are teratogenic, so many of them are contraindicated. So we prefer always monotherapy in such conditions, and we use the lowest possible dose. Medications that are safe during pregnancy, or let's say more safer than the others: lamotrigine, gabapentin, and oxcarbazepine. The drugs that are contraindicated: valproic acid, phenobarbital, phenytoin, are definitely contraindicated because they may produce cleft lip or neural tube defect. Hepatic enzymes: we mentioned some medications that may increase or induce liver enzymes, such as phenytoin, carbamazepine. Barbiturates, such as phenobarbital, can produce as well increase in liver enzymes. Some other medications can inhibit liver enzymes, such as valproic acid and felbamate. And some other medications has no activity. Thank you so much, and I hope you enjoyed the lecture. Please let me know if you have any questions.